You can really see how everything hinges on finding that manubriosternal joint. By anchoring your entire technique to this one single landmark, you basically guarantee that V1 and V2 land in that fourth intercostal space, and that V4, V5, and V6 are all perfectly lined up in the fifth. This is the only way to get a repeatable, accurate diagnostic ECG.
Of course, even with perfect placement, you can still get a messy tracing. So let's talk about taming artifact, which, let's be honest, is often a battle against the patient, the equipment, and the environment itself.
Artifact really does come from everywhere. Is the patient moving, talking, or shivering? Well, you're going to get a chaotic baseline, so job one is to keep them warm and relaxed. Technical issues are also huge. Old, dry electrodes, bad skin prep, all of that increases impedance and noise. And finally, check the environment. Cell phones are a classic culprit, but also look for electrical noise from things like motorized hospital beds. Seriously, sometimes just unplugging the bed can fix your trace instantly. All right, theory is officially done. Now for the fun part. Let's run through a few quick clinical challenges. I'll give you a scenario, you make the call. Ready? First one up. You glance at the ECG, and right away you notice that everything in lead 1 is pointing down. The P wave is inverted, the QRS is negative. What's the error here? Yup, that's a textbook right arm, left arm lead reversal. It's the most common limb lead error, and thankfully, it's also the easiest to spot. That inverted lead eye is your big giveaway, every single time.
Okay, scenario 2. A young patient's ECG shows what looks a lot like a Brugada pattern in V1, which, is a potentially life-threatening finding. But you palpate the patient's chest, and the electrodes feel like they're way, way up in the second or third intercostal space. So what's going on?
This one is so critical to catch. Placing V1 and V2 too high is the #1 cause of a pseudo-Brugada pattern. When you move those leads up, you're getting a totally different electrical view of the right ventricular outflow tract, which can create that scary-looking morphology. This is a misplacement that can lead to a huge and completely unnecessary clinical workup for the patient. All right, next up, the precordial leads look totally fine, but the QRS complexes in all the limb leads are teeny tiny. You find out the limb electrodes were placed on the patient's shoulders and lower abdomen just to make things, quote, easier. What's the cause of that low voltage? That's exactly what happens when you place limb leads on the torso. This is sometimes called the Mason-Leaker placement, and it's meant for stress tests, not for diagnostic resting ECGs. It moves the electrical viewpoints much closer together, which dramatically shrinks the recorded voltage. It can make you miss important findings or just misinterpret the tracing entirely. Okay, one more. The baseline on your trace is just thick and erratic. You can barely even make out the P waves. You look at your patient, they're in a thin gown, the room is cold, and you can see they're shivering. What's the problem, and what's a simple fix?
That is classic somatic muscle tremor. The electrical noise from all those shivering muscles is just completely overwhelming the cardiac signal. And the simplest fix is often the best one. Just get the patient a warm blanket. Making them comfortable and relaxed will often clean up that trace beautifully, and you won't even have to touch a single filter setting.
And for our final challenge, let's boil everything we've talked about down to one question. If you remember nothing else about precordial leads from this, what is the one landmark you absolutely must find to get it right? The angle of Louis. That's it. That's the answer. If you can reliably find that little bony ridge on the sternum, you can nail your precordial lead placement every single time. It truly is the key that unlocks a diagnostic quality ECG and helps you make sure you're giving the absolute best care to your patient.
In the world of emergency medicine, there are a few things as time-sensitive as a stroke. Today, we're going to do a deep dive to really sharpen those clinical tools you need for rapid recognition and, most importantly, decisive action. All right, let's jump right in.
I want to start with a number that should honestly stop every single one of us in our tracks. 1.9 million. That's the average number of brain cells lost for every single minute a large vessel stroke goes untreated. We've all heard the phrase, time is brain. Well, this is why. It isn't just a clever saying, it's the physiological reality we are racing against every single time. So when that clock is ticking down this fast, our assessment has to be faster, and our decisions have to be sharper. There's no room for error. Let's break down the essential tools you need to make the right call right away. So, let's start with the basics, the absolute foundation. This is the universal first step in stroke recognition that everyone, from a bystander on the street to a seasoned paramedic, needs to know inside and out. I'm talking about the fast mnemonic. First up, F is for facial drooping. Pretty straightforward. You're going to ask the patient to give you a big smile or show you their teeth. What are you looking for? Asymmetry. Does one side of the face just kind of sag or refuse to move? A crooked, uneven smile is a classic sign.
Next, we've got A for arm weakness. Here's what you do. Ask the patient to hold both arms straight out in front of them, palms facing up, and hold them there for about 10 seconds. You're watching for one arm to drift down or maybe turn inward. That's what we call a pronator drift.